Thank you very much for this opportunity to speak to you. And by my side is my trusty sidekick, Kate Furman, and she knows the answer to all the questions you have about money.
Don't oversell.
So Keisha, if you will start, please. So, in keeping with the governor's strategic goals, obviously our lane is in keeping people healthy and safe, but we believe in responsible and efficient government, and we believe in growing to do better for our state. Our total budget is $632.7 million. Of that, 63% comes from federal funds, with a big majority of that going to WIC, which is our Women, Infant, Children program, and the state general funds are 33%, with about almost half of that going directly to the counties for grant in aid. And there are 3 decreases, one-time decreases in this budget, and the rest of the money is increased money. And so I'm going to go through those changes that are listed. That we are starting at 38.1.3 in your tracking document. And I want to say something that the majority of these changes have to do with nursing salaries. And they appear in different parts of our program because they are applicable to nurses that are working in those areas. We are one of the organizations that has had a significant turnover, and we are very appreciative of the additional monies that are put in for those high-risk turnover organizations above the governor's proposal for the increase across the board. So these are additional monies that are represented. The first is in our adolescent and adult health promotion. There is the elimination of the one-time fund that was in the budget for GeorgiaCancerInformation.org website, and you can see the increase of a little over $2,000, and again, that's for the nurses that are involved in that program. Next is administration, and these are monies that apply to nurses in our chief nurse's office, and you can see all the monies in that department are for increased monies to nurses. The next one, which is 38.7 in your tracking document, there are 3 things that are in this particular category. One, there was a decision by the governor's office to transfer the MECHA funds, which are federal funds used for home visiting programs, to transfer it to our department. We are very thankful about that. We think that that's an efficient and appropriate place for those home visiting grants to be, but it does. Hopefully, you will agree that that's a good move, and your decision on that is just yay or nay. There also in that are monies that came from last year's budget, and that's an increase in that $1.7 million that will provide medical food for children with congenital disorders. Those increased monies come from an increase in our newborn screening, and the next slide will explain that. But that's an increase of $1.7 million, and again, the recommendations of the governor's office is the elimination of one-time funds that were put in the Sickle Cell Center, and that's at Grady Hospital. The next is an elimination of infant and child promotion that was a one-time amount for $25,000 that was in the Raleigh Foundation for Childhood Cancer Research. The next is the explanation for newborn screening. There are 3 really changes this year. One is we have added on our blood spot a new test that will be done at our state health lab, and that's for severe immunodeficiency testing. That is a new test that is recommended nationally, and we are pleased and it's appropriate that that be put in our newborn screening. In addition to that, we have added testing at the hospital for congenital heart disorder. That is universal screening for newborns. The monies for the blood part, which come to our lab, the fee will go up from $50 to $63. That increase in fee will generate those monies, that $1.7 million that will be used for those children with congenital disorders. The newborn screening, of course, one of the main things it does is check for children with congenital disorders. And certain babies are not able to process certain foods and need special medical foods, and that is the device to provide that for Georgia's children. So the next for infectious disease control, you can again see the increase in nurses for the Office of Family and Children's. There is a transfer of funds from the Governor's Office of Children and Families that has been transferred to Public Health. Again, we are very appreciative of that transfer because we really like the idea of the coordination of services in Public Health of all those child services that are with the state. The next, there are two parts in the monies that go to the counties. The first is the grant and aid hold harmless. This year, the recommendation in the governor's budget, there are 2 more years in that 7-year phase-in for the change that we had in the proportion and how we proportion monies going to the counties. This $2.1 million is for both of those years. The next, you will see that $1.8 million, that again is the nurses' money. That is a significant number because obviously the nurses in our county health department, that's the core of our workforce, that's the center of our work there, and so that is a larger amount of money, and that will be directly passed through to the counties. On the next page, you see the change, the vital records facility. We talked to you about that last time that we needed to move, and this is our money for rent. So that's placed in this year's budget. Then it follows the statewide changes that are for all departments. The merit-based pay adjustments, and that does not include, of course, those additional monies for nurses, which I've described as I've gone through, and also adjustment to DOAS, Administrative Insurance Program, and adjustment in TeamWorks. All those are passed through for different departments. You can then see on the next page that the total change in funds for us is $14.8 million increase, and on this page you can see the Georgia Trauma Care, which is an attached agency. The increase is recommended for them, and you can also see the data that's attached to us at Tobacco Settlement Funding, and there's no change in that for us this year. Next, there are general obligation bonds. As we have talked to you, we are in the process of doing an update and a standardization of our IT systems throughout every single health department. And for this year, the part we are requesting from the obligation bonds is the amount, the $4.8 million that will go directly to claiming and payment. If public health is going to be sustainable, we really have to have a module to make sure that we realize those monies from private insurers and from other providers so that we are able to sustain the services that we need to give. There's also the $400,000, and that's for lab, basically update and upkeep for our 2 labs. Next, I want to talk to you a little bit about the key initiatives for public health. This is where your money goes. This is what you're buying for it. We have 5 major medical initiatives. We have 2 safety initiatives that we want to talk about, and the third are those that have to do with the development of the Department of Public Health itself so that we are an efficient agency that can manage to do work. The workforce development, the biggest part of that, of course, is the increase in nursing salaries, and also the systems, enterprise systems modernization. That's the IT program that we mentioned just before this. So, in childhood obesity, this is the Georgia SHAPE program, and as you know, we are in the 3rd year of implementing that, and what you see on this slide, when it goes up, those are children that are in a healthy weight. So our plan was to improve childhood obesity rates in this state by 1% per year, and we are on target to do that. I'm very pleased with the public-private partnership that is addressing that, and very pleased to see that we are marching right along in achieving those goals. Yay, team. So one of the big parts of it is the Power Up for 30, and that is a system where we have 30 minutes of increased physical activity every day, every school, every child in Georgia. We had some funds that were given to us, and this is the last year of that funding. So if you look on those counties in red are the counties that have not signed up yet. If any of those your counties or your colleagues serve those counties, please tell them it's this year. But that part of increased physical activity is certainly, I think, one of the most important reasons why we are having those improvements in childhood obesity. We intend for this to be sustainable. We are working with the University of West Georgia to make sure that that's put in basic training for new teachers coming out of the schools of education, and we intend for Georgia's children to continue on this march of an improvement of 1% per year. The next has to do with early brain development. As you know, you gave us money for autism last year. And one of the things that I think to remember is the most important part about autism, the most, I think, exciting part is that if you do that, if you identify children early enough, there are therapies that can be put in place that change the trajectory of that child, so that child can go to a regular school, so that child can become employed. Those therapies depend upon early diagnosis, and those therapies have to do with interaction with the child at that very early formative stage, so children learn different ways of interacting. The problem with autism is a difference in the way children interact, and the Autism Navigator teaches parents there's no child that can change that with just 30 minutes 30 minutes of therapy per week. It really needs to be a daily change to affect what we need. And the Autism Navigator teaches people to teach parents how to do this on a regular basis. So we're working closely with the Marcus Autism Center. We have worked with, and with the monies that you gave us last year, we have trained 44 additional psychologists in this way of interacting with children, both in the diagnosis and the early therapies, and we are targeted for 25 more psychologists this year. And we have also targeted, again, you do not have to have a psychologist to do this training. There are BS levels of people who can teach parents how to do this. And when we talked about the 100 providers, we're talking about more people that can provide therapy for autism. Because clearly, one of the things that we know is a problem is making sure that we have therapists to interact with children at those early stages throughout the state. The next I'm going to talk about a little bit, and I'll be willing to answer questions if there are any questions. We came up with a name for the public-private partnership that's the overarching early brain development. We called it Brain Trust for Babies, and that involves the Talk With Me Baby program that I've mentioned to you last time that has to do with the language development in WIC clinics. The nursing part of teaching about the importance of early brain development and talking with your baby to advance brain development. That is being enacted this year in the Metro Atlanta, in the hospitals in Metro Atlanta, in both in delivery hospitals, and we are teaching pediatric nurses. We have again gone to the schools of nursing, and this will be part of the curriculum. We've approached the Medical College of Georgia, and it will be part of the medical curriculum there, and they have agreed to champion that as medical curriculum throughout Georgia. So there's a lot of good work in early brain development, and of course the most challenging babies are those autistic babies. So the monies that are in autism, all of this is under the umbrella of the Brain Trust for Babies. The notion is that there will be a universal design for brain development with specialized programs for specialized children, for example, the deaf and hard of hearing. So, the next part is telehealth. You know, we have used our WIC money to develop a telehealth network, and we now have telehealth capabilities in all public health districts. We have deployed 16 carts, and in just the public health part, not the referral clinics, but in just our patients, we are seeing about 300 patients a month through our telehealth facilities. So that is, we have 6 more carts to be deployed this current year, and if you turn to the next, you can see that we are beginning to expand the use of this network. Our partnerships in behavioral health are particularly important. We have programs going on with them that use existing rural health nurses to diagnose and assess and connect clients who need behavioral health treatment with people in Atlanta or in other places. We also have school-based telehealth projects and pediatric primary telehealth projects going on. And if you look at the next, we are again working with private companies because this telehealth network, we see it as a public commodity. We think that we can expand access all throughout Georgia using the public commodity of telehealth of our networks. We are working with the dermatology department and with a member of our board who is Robert Harshman to develop, and again, this is a private company. And we are also doing such things as sickle cell telemedicine pilot program in Dublin, Waycross, and Valdosta. We see this as a very viable way, again with that public commodity of our telehealth network to provide increased services throughout Georgia. We used bond funds this year, and we are at this moment installing systems which will keep our network HIPAA compliant and also able to talk to any telehealth network in the nation. So that makes us not only in every county, but also ability to communicate with any other telehealth program in the country, and we think that's very, very important. Our other initiatives, cardiometabolic syndrome, that is diabetes and hypertension. Those diseases have similar kind of etiologies, and we really need to increase work. We have published our action plans, and that will have to do with public-private partnerships because, quite frankly, there's not a lot of treatment money in public health for those therapies, but we are trying to expand the resources that we do have to reach as many people as we can because cardiovascular disease and diabetes are the most important health problems we have for adults in this state. The pediatric asthma, public health has a unique role in pediatric asthma. If you look at, we have looked at, done the evaluation of where the trigger points are for asthma. The trigger points for asthma are in the home. Our environmental health people have developed a program to identify which homes are more at risk based on neighborhoods and based on the age of the home. And we are doing some collaborative work with the Department of Community Health to do home assessments for asthma because clearly what we need is to prevent those cases from occurring. The other thing that we did this year that is unique to public health is we have made pediatric asthma death a reportable disease. That means every single pediatric asthma death will be investigated, because pediatric asthma deaths should be preventable, and we want to make sure that they are preventable. And so we are identifying it when it occurs and investigating it. The next on emergency preparedness, the big news last year was Ebola, and we monitored over 2,900 individuals for 21 days in this state. And we, of course, did not have any positive Ebola, and we are no longer actively monitoring travelers as they come in, although travelers are still coming to the state and are being self-monitored and we are giving them access to us should they need that. But the big story this is now Zika virus. Zika virus is transmitted by mosquitoes. For adults, it's a pretty benign disease. If you get it, only 1 in 5 will become sick, and basically it's flu-like symptoms. Joint aches, you feel bad for about a week, you get the pink eye, you get conjunctivitis, and then if you're an adult, about a week later you're fine. The problem is in pregnant women. In the South Americas, there have been over 4,000 children diagnosed with, it's called microcephalia, which means that the head does not develop properly. There are neurologic problems, there's problems of actual brain development, and it's caused by the mother's exposure to this virus. At this point, we do not have any positive cases that have been identified in this country. We have 7 cases, and of those, 2 of them are pregnant, who are travelers to that part of the world. We are waiting from the results of their tests from CDC, but those were travelers. We obviously need to be very carefully monitoring this and we need to really start thinking about mosquito management programs for the summer, because it's all through South America. It is in Mexico. It is in all the islands. It's in Samoa. So it is widespread in South America with this year. Brazil. Exactly. Worrisome. So that is top on our radar right now. We are simply monitoring travelers. We have, if you want to learn more about the disease, go to Public Health Georgia Department of Public Health, and on the front page of our website there's a Zika virus, and you can go down and you can see if you're traveling to those South American countries. One, if you're pregnant, don't go. But if you're traveling to those countries, the recommendations for what kind of mosquito protection you should take, what you can use to protect your clothes, and one of the things will be a huge campaign this summer. The mosquitoes that are involved with this really tend to be in standing water around homes. So that means we're going to be getting those public messages out, I'm sure this summer, about, avoid standing water around your home. That's going to be, we're going to be monitoring that very, very closely. In addition to that, I thought it'd be kind of fun for you to see that we inspected over 62,000 restaurants this year. So we're trying to keep the good work going and keep people healthy in Georgia. The next slides have to do with our public health nursing workforce. And as you can see, the first slide, the number of people in Georgia have increased, the number of nurses has decreased. So that means we do not have a significant number of public health nurses to provide that screening for cardiovascular disease, to do those prenatal clinics, which in combination with private practitioners can do good work in lowering prematurity rate, and it certainly doesn't have people to screen for immunization or or various other diseases. So we are very thankful for the increased monies that have been put into the budget for our nurses, because you can see we have decreased our total number of nurses by 33%, with the majority, the main reason being given are non-competitive salaries. We are about 20 to 30% lower than the private sector for the amount of monies we pay our nurses, and our nurses are dedicated, and in public health is a great place to work, but we are thankful for any relief you can give us for competitive salaries. The other things I want to emphasize, you know about the low THC oil registry. That is up and is going well. You passed that. It was signed into law last April, and 2 months later in June we launched the registry. We now have 213 physicians that are signed up on the registry, and we are serving 545 patients as of the end of January. And the vast majority of those are children with seizure disorders. The other thing, we have completed the vital records update. You gave us money for that, and as you can see, we are improving customer service. Our wait time, we served over 3,500 customers at our state office, and our wait time is less than 15 minutes from the time you walk in to the time you're served, and we're pleased about that. And our call time has improved. We've gone down from you hold the phone for 9 minutes to you hold the phone for less than 2 minutes, so we're pleased about that, and consequently you can see people aren't hanging up on us. Our abandonment rate is better. So all in all, I am pleased to tell you that the Department of Public Health is growing. We're trying to improve, and we thank you for support, especially for support for the monies for our nurses. Thank you, sir.
Good. Thank you, Doctor. I'm sure we probably have some questions from committee members. Anybody? Representative Hughley has a question for you.
Yes, ma'am.
And what we're doing in that area. I know we have some projects in different parts of Georgia, but it doesn't seem like we've covered that well in the Columbus area. And that's something that my constituents are asking me about. What are we doing to help our residents that are suffering from sickle cell in the Columbus area? Can you speak to that? I see we're getting rid of $50,000 at this time on sickle cell. If y'all don't need it in Atlanta,
I hear you, and I absolutely agree with you. I had an interesting discussion. The public health doesn't. We don't have really the folks to. We don't have the medical force to treat those patients. Our main ability is to provide access with our. I think our main thing is to provide access with telehealth. We are working with the University, the Medical College of Georgia. I'm sorry, that's one of the, and they're able to do to see patients. But you're right, we really need more sickle cell coverage across the state, and that's why I'm pleased with that project that we're doing. I mentioned it, the project that we're doing in those 3 sites, because I believe we need more of those throughout the state. We have in HIV, we had a situation where we really didn't have HIV services, throughout the state. We hired one HIV specialist, Dr. Felzine, who's an infectious disease specialist. He can now sit in Atlanta and see patients in every single health department throughout the state. I believe a similar model for sickle cell would be very advantageous, because you're right, we don't have enough providers, and we don't have enough providers where they need to be. You tell them if anybody wants. As a matter of fact, we have a pediatrician who is interested in doing more clinics in that area. We will be glad to work with you to expand the sickle cell project, because it's going well. And if you would like a telehealth component of that, we're happy to help you do that.
Dr. Fitzgerald, you alluded earlier about the Zika virus, and with the Olympics coming up that we talked about, and I think I read that the World Health Organization had just sort of declared an emergency on this.
Yes, sir.
Do you think that there are going to be any needs that the department needs to be thinking about, or that probably weren't considered when this budget was put together and that sort of thing? You want to talk about that a little bit for us?
Yes, so I believe, and you're right, because this is newly acting. I think as far as needs, we really do need mosquito control. So our environmentalists, and we have not looked at how much money we would project, but we would be glad to predict that for you, because we certainly, again, the mosquitoes that transmit it have been shown. They cluster around homes, and I can tell you an example of a mosquito-borne infection that was in Taipei, Taiwan, which is again a metropolitan area, and they went out in that entire country, both in the rural parts and the urban parts, and did a conscientious mosquito control around homes, and dramatically reduced the exposure. Because, and I really think that that's the attack we're going to need for mosquito. Well, that's what I'm saying. You don't get the benefit necessarily by spraying the whole state, but you get the benefit by making, if you have standing water around your house, putting mosquito bombs, they're called, in that water. You know, making sure your drains aren't collecting and that sort of thing.
How about if you put something together with some cost and some information for us, that would be helpful as we move forward on this.
Be glad to.
Representative Gardner has a question for you.
Thank you very much, Mr. Chairman. I have several questions.
That's not a surprise.
No one's surprised. I'm sorry. I want to start by applauding your efforts in the department. It's very heartwarming to see what you've been able to do with not very much money. But
Thank you. Have a great
Thank
team.
you for what you do. As you know, I've been working on the transition that's going on in Fulton County, and wanted to clarify for everybody that should the Fulton County Health Department become like the other health departments, the only employees who would be state employees would be the director.
Yes.
So the other employees that are currently county employees would continue to be county employees. Is
Yes,
that
ma'am.
correct?
That's right. The most important one is the health director themselves. That's the one that has the direct, and we have recommended to this body something called a cadre. And that's a number of services that need to occur in every single county. And we would suggest that, but it's just those top people for those top services. So we're looking to make 5 people.
So in Fulton County, you're looking at 5 people that would be on the state payroll,
Yes.
as opposed to the,
But the most important one is the health director.
The health
That one, and the cadre is what we have recommended as ideal, and that's not been implemented everywhere. But everywhere, the district health director, that's a state employee. That's how we connect everything to that main head doctor.
and so are you working with Fulton County? Do you think you're going to be able to pull this off without additional funds?
We are working very closely with Fulton County, and Fulton County has been great to work with, to be perfectly honest.
Great.
They invited me, for example, to be part of their panel that interviewed the people they were looking at for health director. And I am very pleased to report that Dr. Kathleen Toomey is becoming your health director there in Fulton County. And she has been in Botswana. She has been in the state public health office. She has been at CDC. The last 5 years, she has been in Botswana dealing with HIV specifically. So she brings state, local, and international talent to Fulton County, and I think she will just be a tremendous asset for Fulton County.
Another question? When you're looking at all the screening that you need to do for children, and I'm particularly interested in the good work you're doing with autism, but the federal government through Medicaid has a program called EPSDT. Now, do your health centers take advantage of I mean, it's not just diagnosis, but treatment that is supposed to be provided through that program?
We do PCSDT screenings, and then, yes, we do that.
And then if the person needs treatment in autism, it's really, there are lots of people learning to diagnose, but then we've discovered in the state plan that the $2 million we put in for the state employees has been very underutilized. I mean, maybe 180 or 200,000 of the $2 million.
One of the things we looked at is that if you utilize the autism navigator that we're talking about,
The autism navigator
that we're talking about in here, they're called community health workers, and those folks can do that. And the program calls for, is it 18 months or 36 months? I can't remember. I'm sorry. I can't remember.
You're talking about the training or the actual working with
the actual working with the families. And the ideal treatment program is to do 3 of those interventions with the family, with the community health workers. And I'm sorry, I can't remember right this second if it's 18 months or 36 months. But we've looked at that and documented that, and we have asked for we worked with Department of Community Health and have asked for a state waiver on getting those people covered by Medicaid now, where now there's coverage for like psychologists, but not necessary for that segment of worker. But we think that would go a long way with our Babies Can't Wait money to really, in a realistically way, finance that early treatment of autism.
So they would be people that would be trained in the ABA or ABA-like therapy?
Yes.
That's great. So you would get them in the communities around the state.
Yes. And again, if you have them at that level, if we can get the state if we can get the feds to agree to that, then that's a way that we can, those folks are in the communities. I mean, getting a PhD or a psychologist to go to that may be a lot more difficult than having the people there that are already doing Babies Can't Wait monies work to be trained in that autism piece, both in the diagnosis and the therapy. I think I'm excited by that. I think that's the answer to the problem.
Yeah, I think in terms of the therapy, maybe not the diagnosis, but in terms of the therapy.
Yes, I'm sorry. Yes, I agree with that.
One last one?
We'll come back to you.
Okay, that's fine.
Representative Quick has a question.
Thank you, Mr. Chairman, and Dr. Fitzgerald, thank you for your presentation. Thank you for your work and for bringing us demonstrable good news when you come to see us and present to us in a coherent and verifiable way. I appreciate it. I just have a question somewhat connected to Representative Gardner's inquiry about Fulton County, and that is, with regard to the state general funds, how much of that is the grants in aid to counties? What's the formula that you use to make those grants in aid? And then how many counties are we talking about, or centers in counties across Georgia?
Okay, the grant and aid, we had a very inconsistent way to divide those monies up. If you look at the state monies of that $209 million, I think it's $101 million of that goes directly to grant and aid. And those are pass-through monies that you give to us that we send directly to the counties. Those monies are decided. A new formula for how we divide up those monies was agreed upon by all the counties about 5 years ago now, based on the population, based on the number of people in poverty, and based on the percentage of the folks in poverty, realizing that in those counties where there is a greater burden of poverty and a greater proportion of poverty, that we would need a more advantageous amount of monies to go to those, because we need to be the safety net. So that was agreed upon universally about 5 years ago. To get from that distribution of funds that was erratic to the distribution of funds that is consistent and changes by population and percent poverty, we went on a 7-year plan. For example, in Chatham County, they had about, was it $2 million more per year than if you went by the formula that they were allowed to get. And other counties had significantly less. So we are now 5 years into the process, and this money in the budget, that $2.1 million in the budget, is to complete that transition, so that in 2 years we will have we will agree upon those funds, and they will change every 2 years based on population. Does that make sense?
Yes, ma'am, it does. And so on your website or somewhere, can I find a county-by-county distribution?
I'll get that to you.
I have a copy in my purse.
Well, thank you, ma'am.
I'll give it to you before I leave.
And may I ask one more thing, Mr. Chairman? With regard to the county health departments, do they actually bill for Medicaid services, so that
Yes.
DCH or CMO is
Yes.
a middleman back to the health departments?
Yes, and that's one of the changes that really has been, I think, most dramatic since we became a department. We have aggressively started working on billing both Medicaid and also in an attempt to recover monies from private insurers, because we had, I think, an over-reliance on the federal funds coming in to provide treatment monies, and one, that's a decreasing amount of money, and two, that's just not sustainable. So we are aggressively going for, and it's a sliding fee scale. So what that means is, if you don't have the money, we're going to treat you. That's not the notion. But if you have an insurance source, if you have a Medicaid, we want to make sure that we bill it.
And is there centralized tracking for that through the state, or that's on a county-by-county basis? You have to drill down into that.
It's on a county-by-county basis, and that's what in the bond money, when it talked about that payment and claimant system, that's what that's for, is a centralized system, so that we will know that we are not missing any significant monies. In order to do that, there were 4 different computer systems, and one of the computer systems, there were multiple versions of it. So when we became a department, we had a very disjointed internal system that didn't. We had a culture that didn't routinely bill. We had IT systems that didn't talk to each other, and we had an over-reliance on federal funds to cover our needs. So that has all dramatically changed, and hopefully when that gets implemented, that will be implemented in 2 more years. That will be done. We are doing an integrated system of all of that. Our claimant and payment is also involved in our system. So, for example, our WIC money we want that to be the same system. One, because that means we can use WIC monies to help pay for our total system, but that puts some restraints on the speed with which you can move through the entire process, if that makes sense.
It does, and thank you very much. Appreciate it, Commissioner.
Just to bring you a little up to speed on that, prior to Dr. Fitzgerald's arrival at this department and her team, we had a disjointed system that the right hand didn't really know what the left hand was doing, and when she got there, she found out that some counties were billing, some were not billing. If they didn't have the proper system, it just got shoved over to the side and probably never got billed. And part of the thing that this legislature has done over the years, they've supplied her with money to try to make a system that's statewide and uniformity in that system, and part of this bond money would go one step further so that now she can keep up with what the counties are doing, making sure that they're billing when it's, it's proper, and try to recover whatever resources they should. So good job on that.
We
Thank you.
really appreciate your help on that.
Representative Hawkins has a question.
I just wanted to ask about the newborn screening. I know years and years ago we had some folks that wanted to be involved in that. And at that time, I think it was all sent to Grady. Is that still the case, or what are we doing with that?
Well, we actually,
It's all sent to our private lab, to the public health lab in Decatur.
Great, okay. And so when we're talking about an increased fee of $13, that's the cost to do it, I assume, then, because we're not in the money-making business with this.
No, sir.
We're not making a profit.
We're not making a profit. There's a little bit of extra money that's generated by that's used to pay for the medical foods.
Okay, good.
So that's that's a little bit of money is $1.7 million. That's a big little bit of money. But that's extra money generated. But then what we did is we put that into medical foods. So when you pick up a problem on that screening, those medical foods can help treat that problem.
Right. Okay, great. Good to hear. Thank you.
Our last question, Representative Gardner is going to have that.
I had the pleasure of visiting the Poison Control Center, which I always thought was at Grady, but is in fact the state Poison Control Center with federal money, and was very impressed with their call center, and was interested to learn that Fulton County, for example, contracts with the Poison Control Center to use that call center for all kinds of emergencies. And I also learned that the Stroke Center, which is at Grady, requested to have calls come from all over the state, not quite like telehealth because there's no visual, as I understand it, but so that a stroke expert who's 24/7 at Grady or Emory would be available to any doctor anywhere in the state through that Poison Control Center, which maybe they need to change their name, but it was a very impressive facility. I was very impressed, so I hope that there will be money for them to begin that different kind of telehealth.
Well, we agree, and I absolutely agree with you that they're tremendous. When we were in the middle of our Ebola crisis, that 866 Pub Health, that went through them. And so the number would go to them, so they'd be there 24/7, and they would immediately transfer it. And I know that one weekend I was at home and I needed to talk to the state epidemiologist, and I couldn't remember her number because I was someplace. So I called that Poison Control Center, and I talked to her in 3 minutes. So they do good work.
It's remarkable, and people there are somehow all in the medical field one way or another, so they're knowledgeable.
And they're able to adjust, like when we needed a lot of call people for the Ebola Center, they were able to very quickly, add capacity. So that it's a good resource.
So is there funding in this budget for their?
not at present.
Not that I know of.
Do we know what I guess they'll come tomorrow and ask for a specific amount?
We can reach out to them and talk.
I know we
got some number.
The contract money, I know we still contract with them because we still pay them for, we will find out that exactly.
We pay the Poison Control Center for a number of services, so we can find out what we need for the
additional service.
Okay, apparently they'll be here tomorrow too. So.
Okay.
Yeah, and I'll be glad to ask for you because I know that we gave them extra money, for example, during the Ebola situation.
I actually think I got an email.
And they will be ready for the next.
Yes.
Right.
Yeah. Can you remind me whose district Grady is in?
You'd be interested to know that it's really right at the edge of my district.
Okay. Any other questions, Dr. Fitzgerald? Dr. Fitzgerald, thank you very much for the good job you're doing, Kate. Thank you for y'all being with us today. A lot of good information. We appreciate you being here.
Thank you, sir. We appreciate your support.
Thank you. Next, we're going to hear from Dr. Dennis Ashley. He's the Commission Chairman of the Georgia Trauma Care Network Commission.
Okay. Can you hear me? Well, thank you, Chairman Parrish and members of the committee. I appreciate the opportunity to be here today. Dina Abston is to my right. She is our interim executive director of the Trauma Commission, and she'll be here and hopefully help to answer any questions if they come up. Again, I'd like to thank you for what you do and for your support of the commission. And as you see, next slide, Dina. Our funding comes through the super speeder. That's on slide 2 of your handout there. Is the super speeder law that generates all of our revenue. All the revenue for the trauma system comes through this one law. Next slide. Just to show you what the revenue has been, here's the historic data on that from 2011 down to projected 2017. You see the revenues have really picked up. In 2015 we hit $23 million. 16 is obviously still being collected. It's projected at 20, but we'll probably go over that number. And you see the projection from the Department of Driver Services for 17. You see that our budget, we stay right at about 16.3 million. Next slide. Just to break this down into readiness costs, you've seen this slide before or one similar to it, of level 1 and level 2 trauma centers. If you look at 2017 there, fiscal year, the governor's proposed budget is $16.3 million. That funds 6 level 1 trauma centers, 10 level 2 trauma centers, with a readiness cost of about $66 million for all the trauma centers added together. Readiness cost is the amount of money that goes into the trauma center before they see the first patient. So having call teams ready, having equipment ready, everything that needs to be present before you get started. You can see there in the next column we fund about $4.7 million of that, or about 7 cents on the dollar with our current budget. Next slide. For uncompensated care claims for level 1 and level 2 centers, you see in 16 that's going to be about $39 million. We funded about $5.4 million, or about 13 cents. We don't have the data yet for 17. That's undergoing audit right now, and we should have those numbers any time. But I suspect they won't change much from the 16 numbers. Next slide. This is an overall look or snapshot of the governor's recommendation of $16.3 million. You see our proposed 2017 budget breaks down to about $11.8 million for trauma centers and physicians, which is about 72% of our budget. $2.7 million for EMS stakeholders, or about 17% of the budget. And you see the rest there from system development, Department of Public Health, Office of EMS and Trauma, Commission Operations, and the Georgia Trauma Foundation. Next slide. More specifically, if you look at the trauma centers and physician funding, that $11.8 million, again, the readiness cost, it covers about 7 cents on the dollar, or about, for our level 1 and level 2 centers, 50% of that readiness cost is based on performance payments. So trauma centers receive some of that readiness cost up front. Once they meet performance metrics, then they receive the other part of that. So there is a performance-based payment plan which is working very nicely for our trauma centers. We've been able to really make a lot of accomplishments by having that kind of pay model in place. Uncompensated care reimbursement, as I said, we cover about 13 cents on the dollar for that when we've audited all the uncompensated care claims. And you see the rest goes for trauma registry software support, updated readiness cost survey so that we know what the costs are, and then the uncompensated care claim audits. Next slide. This is really what you're paying for when you look at the trauma centers. If you look at the upper left-hand corner of fiscal year 2008, you see we had 4 level 1s and 9 level 2s, no level 3s, and no level 4s. tremendous improvement since 2008. If you look at the lower right-hand corner of your slide, you'll see currently we have 6 level 1 trauma centers, 10 level 2s, 2 fully accredited burn centers, 5 level 3s, and 5 level 4s. Now, I do not sit here and take credit for all that. The Office of Emergency Medical Services and Trauma with Dr. Fitzgerald and Dr. O'Neill deserve all the credit for this, as they have fought hard to designate these centers. The Commission, working hand in hand with them, has also helped recruit, and it has truly been a team effort. So we've come a long way in what I think is a short period of time. Next slide. The EMS Stakeholder Funding, 17% of the budget, about $2.7 million. You can see the items that are listed there. We don't expect these projects to change too terribly much for the next year, but you can see some of this is devoted to equipment or upgrades. Some of it is education, and some of it is support of the regional trauma advisory committees in those communities. Next slide. You see system development and access as listed here. Again, this covers things like education for rural areas, TQIP, which is an acronym, you see, Trauma Quality Improvement Program. Our state participates in that. And again, Georgia is the second nation in the country that has been able to have every level 1 and every level 2 trauma center participate in that program, which evaluates our outcomes. And we are really, other than Michigan, we're leading the way there. Now, what, as far as the budget there, what impact have we made with that budget? The next slide you see here, this is data that's been published in the journal, or the Journal of Trauma, was just presented at one of the national trauma meetings, and this came out in April of last year, in 2015. And you see, I presented this slide before, but it's actually published data now, and we've been able to show a difference in survival for critically injured patients treated at a designated Georgia trauma center versus a non-trauma center. You see the numbers there. For all severely injured patients, that survival advantage is 9.6 or 10%. If you look at the most critically injured group, it rises to 16.5%. Intermediate critical, 22%, and then the least critical, 8.3%. So however you slice it up, there's a tremendous survival advantage when patients that are critically injured are treated at Georgia trauma centers versus non-trauma centers. Next slide. If you look at access now, what about access? Are we doing a better job of getting patients to the trauma centers? And you can see the years of coverage there from 2003 to 2012, and you see that bend in the curve at about the year 2009. And if you look at the circles and the dotted lines, you see that we went from 40%, we've gone from 40% up to about 59 or 60% for all severity levels. So we're not just getting critically injured patients to trauma centers, we're also getting all types or all severities there. We've made a tremendous improvement, about 20%. If you look at actually look at the square, you see that we've gone from 63% up to 84% for those critically injured patients, and then the triangle shows you those non-severe patients. They've even had a bump up into about the 16 to 20% range. So again, we were targeting critically injured patients. We wanted to make sure that we got the critically injured patients to the trauma centers with the funding that we had, but as a side effect or a benefit to that, we've also noted that the less injured patients are getting there as well. Next slide. Now, just to show you, this is a busy slide, and I apologize. I know nobody wants to go back to math class, but I want to make one point. We wanted to make sure that we weren't just moving patients around from one trauma center to another as we increase the number of trauma centers. And the straight line, the linear line there, shows you what the prediction was for patients going to trauma centers if we stayed the way we were. And you see the black line that goes up all the way to the top. That is the observed. That's the improvement. You see how that goes way above the dotted line. And basically what that tells us that we are actually bringing new patients into trauma centers that did not go to trauma centers before. So the new trauma centers that we've recruited with OEMS&T are actually making an impact. More patients are getting care than got care before. Next slide. Research has been a big focus and a big emphasis. We not only want to do well in Georgia, we want to lead the nation, and we're starting to publish our data. As I said, we've published in the Journal of Trauma with our survival advantage. We just had a publication come out in the Journal of the American College of Surgeons, as you see listed there. This was just published either in January or it's online, but it's either coming out in the February issue or the January issue in print. And this is where we looked at our data. We looked at we scrutinized ourselves. We looked at how we collected data in the trauma centers, and we showed that the areas where we could make improvement, and that's what this paper is about. Again, showing other states how that we do things and how that they can improve as well. Next slide. We also looked at our venous thromboembolism rate across the state, looking at this problem in all trauma centers, and this data will be presented at the Southeastern Surgical Congress, which will actually be held here in Atlanta next month, or actually this month now, February, and will be published once it's presented in the American Surgeon. So again, a tremendous focus not only on our state, but showing other states how that we do things and looking at our outcomes and trying to be better. Next slide. We're very proud of the Georgia Trauma Foundation, which is really starting to get on its feet now. You see the board members listed there. The goal of the foundation is to provide education, injury prevention, and research, and I'm happy to say that they're well on their way to doing that. They're starting to develop partnerships, and over the last 6 months or so, we've started to make real improvements in that area. And then finally, our request to you, based on the presentation, we would like to request an additional $4.6 million be added to the budget that the governor proposed at 16.3, which would basically be the additional funding from the super speeder revenue. It would increase readiness funding from about 7% to 9.8%, which is a modest increase. It would increase uncompensated care funding from 13% to about 18%. Again, which we think is fairly modest, and it would continue to provide additional funding for trauma quality improvement programs, which I've mentioned today, to look at our outcomes. All the work that we've done so far is basically in that arena, in that last bullet point there, has basically been by blood, sweat, and tears and volunteerism. We've published with that, we've made a difference, but we've gone about as far as we can unless we actually start funding that project. So with that, Mr. Chairman, I will stop and be happy to answer questions.
Great. Thank you, Dr. Nash. I want to say thank you to you, and it's pretty obvious if we have looked at these reports over the years that in the last few years especially, you've really made some good progress, and I think the numbers support that. And because of that, you've got a lot of people in this state who are alive that probably would not have been alive had it not been for your Trauma Network Center. Now let me ask you a question about this. I've got a concern about emergency room physicians, and in fact, are we graduating enough through our medical schools and then through our residency programs to meet the needs that are out there now, and how difficult is it for you to recruit ER doctors in your trauma centers? I know you have to have the specialists and subspecialists on your level ones and that sort of thing, but just in general across the state, what are you hearing from your colleagues? Or do we have enough doctors out there to staff the emergency rooms, or do we need to be providing some more?
Well, I think that one of the big problems that we have in medical education now is we have increased the number of, I say we, the colleges and the medical schools across the state have increased the number of applicants. In other words, they've tried to improve the process by graduating more medical students. My shop is frozen for, as residents go, at about, I think about 90 or 95, maybe 100, somewhere along in there of residents that I can train and be funded through the federal government. They have not increased those numbers. So even if, and we're not any different than other institutions, so if you increase the number of medical students that are graduating and then you don't have a training program for them to go to, then they're stuck in limbo, and so you can't ultimately increase the number of doctors, i.e., in this situation, emergency physicians or trauma surgeons, to man those ERs. So yes, in my opinion, again, and I'm not an expert in that field, but that's where I see the logjam is. Last year, we had, when young doctors come out of medical school, they seek a residency program for further training. And there's a match program. They interview, we interview them, and the computer lines them up, and they end up going to a program. Every year there's a few medical students that don't match and have to scramble and find a spot. Last year, I believe the numbers, don't hold me to these numbers, I'm just going off the top of my head, but it was something like 400 or so young medical school graduates that could not find a residency program to go to, that were in limbo. So that's a tremendous amount of firepower there, that you will, that the medical schools have ramped up and have produced medical students ready to go into residency training, but we don't have spots for them to go to. So
was that Georgia medical school graduates?
I think that was, I think that's national, but I'm not sure about
national.
that. I think that's national.
Okay. Well, I know it's a problem. If I'm correct, I think there are only 2 ER programs in the state. One is at here in Atlanta, and one is over in Augusta. And then the rest of us in Georgia, there's not one near us. And it's sort of like if you get hurt, if you're up here, you certainly want to go to a level 1 trauma center. But then if you're out in the other parts of the state, you want them to get you to the best place they can as quickly as you can. But we're sort of out there in the desert in the other part. So I commend you for what you're doing, and we certainly want to work on that. We've got a question from Representative Taylor.
Thank you, Mr. Chairman. It's really more of a comment. This year, I want to really appreciate the trauma centers. I have one of the few level 2 in my district in a rural community, and it is well served and well needed. Between farm injuries, and I had an accident this year, and they had me in surgery within a couple of hours, and that's difficult to do, but being a trauma center, the things were there that we needed, and I got great care, and I really can appreciate it. And all of the rural areas need them, I get that, but I appreciate what y'all have done. Thank you.
Thank you.
Any other questions? Well, evidently you've done a good job. Thank you very much. Appreciate you being with us today. Thank you. Next, we're going to hear from Sherry Tucker, who's the Executive Director of our Georgia Board for Physician Workforce. I think I saw. Isn't she here? Yep, there you are. Hiding. After Sherry, we'll hear from Mercer School of Medicine, and then Morehouse after that.
Ready? Okay, thank you, Mr. Chairman, for having us here today to present the governor's budget recommendations for fiscal year 17. I've provided you with a handout that's a few slide presentations. On slide number 2, I've listed the budgetary programs of the board. We have 6 budgetary programs: administration, graduate medical education, Mercer School of Medicine operating grant, Morehouse School of Medicine operating grant, Physician for Rural Areas, and our undergraduate medical education program. Our fiscal year 16 appropriation is $62.2 million. In the governor's recommendations in your tracking document is 1711, our board administration program. There are 2 statewide changes to the administration program, which are the merit-based pay adjustments and the merit system assessments, for a total of $13,799. And that would bring our admin budget up to $673,000. On slide 4, I'm just outlining some things regarding administration. It covers our personal services and operating expenses. The 16 appropriation is $659,000. It's 1% of our overall budget for 16. We have 5 full-time staff and 3 vacant positions, which are unfunded. All of our research and contract management activities are funded through this program area. And over the last 8 years, we've had a 27% decrease in our administration program. Slide 5 lists about 20 reports that we have to produce annually, either every year, every 2 years, and then we have another time frame for several reports, looking at them over extended periods of time. Slide number 6, it goes into our graduate medical education area, 17.12 in the tracking document. And the governor's recommended change on this is to transfer funds for 72 new residency slots in primary care medicine from the Board of Regents of the University System of Georgia Public Service Special Funding Initiatives Program into our GME budget, and that's $1,138,075. The next few slides just talk about our GME program for a minute. On slide 7, you'll see the contract groups that we have for the various specialties that we have contracts with. The second column are the total residents in training around the state currently. And then the third column are the total residents we have under contract. And these, we do not cover every resident in every program. For example, pediatrics, there are 173 residents total in 5 programs across the state, and we provide capitation funding for 50 of those residents in 3 of the 5 programs. In OB-GYN, we have 100 residents across the state in 5 programs, and we provide capitation dollars for 2 residents at 1 program. General surgery, 194 residents in 6 programs. We provide capitation for 4 of those residents in 1 program. And our newest capitation line is internal medicine, and there are 416 internal medicine residents in 8 programs around the state. And currently, these are all new programs coming online. We fund 15 residents at 2 programs. Then you'll see our capitation rates that are paid per resident and the total funding of each subcategory under our graduate medical education program. Slide 8 and 9 show the capitation rates from 2009 to the 17 proposed, and you can see that in 2009 our capitation rates varied by specialty, with family medicine being the highest at around $22,000. Pediatrics, OB-GYN, and general surgery were hovering right around $18,000. Then the recession hit, and you can see the decline in capitation rates. And through the efforts of this committee and the legislature, we've slowly begun a process of inching them back up. And we're around $18,000, as I said earlier, on the family medicine, and a little above $15,000 on the other specialties. Slide 9, this is just looking at our overall residency capitation, preventive medicine, and then our new internal medicine programs that just started in fiscal year 16 on internal medicine. But you can also see where the rates declined for the other 2 from 9 into 15, and then we're slowly creeping those back up. Melissa, our statistical analyst, is getting ready to work on the final documents so we can give you some new physician numbers on the physician workforce in the state. But I just did want to share on slide 10 our primary care workforce, which is family medicine, internal medicine, and pediatric, represents 36.1% of the total physician workforce in Georgia. 54% of the primary care workforce is over age 50. And almost 9% of those indicated they plan to retire in the next 5 years. Looking at the total physicians, all specialties, 57% of that workforce is above the age of 50. 16.7% of those indicated that they plan to retire in the next 5 years. Slide number 10 is an interesting graphic showing you the aging workforce in Georgia. As you can see at the top, 2006, our age group above age 65, even 64, and above age 55 were the smaller end. And then when you look down at the bottom bar at 2014, that group is growing substantially. So our workforce, our physician workforce, is aging, and we're not bringing a lot of the younger physicians into the state. Next, on slide 12, we have our Mercer operating grant 17.13 in your tracking document, and there are no changes recommended there. But I did want to highlight a couple of areas about Mercer. I know they're going to be presenting as well. Their mission educates physicians and health professionals to meet the primary care and health care needs of rural and medically underserved areas of Georgia. They have 3 campuses, 432 students that are all Georgia residents. Campus in Macon, 4-year campus. Savannah started as a clinical campus, and it is now a 4-year campus. And in Columbus, it's a clinical campus with 3rd and 4th year students. 2 new initiatives in their budget for fiscal year 2016 are Rural Health Initiative and expansion of primary care accelerated track programs. Their 16 appropriation is $24 million, which is 39% of our overall budget. In your tracking document, 1714, which is listed on slide 14, is the Morehouse operating grant, and there are no recommended changes under that program as well. Slide 15, for some information on Morehouse, the mission educates physicians and other health professionals to address primary health care needs with an emphasis on people of color and the underserved urban and rural populations in Georgia and the nation. Their campus is here in Atlanta with 297 total students, which 235 are Georgia residents. And with their class size expansion, the students must be Georgia residents. Their 16 appropriation is $23.9 million, which again is 39% of our overall budget. 17.15 is our Physician for Rural Areas program. And we have 2 recommendations under that program, 1715. One is to realign program activities to provide additional physician rural areas assistance loan repayment awards, which was a yes. And then 1715-2, eliminate funds for the rural dentistry loan repayment program, which is a reduction of $200,000. Slide 17 just gives you some information on this program. We did sponsor a medical fair that brought rural communities together and resident physicians as well as a recruiting effort, and that program was not funded in fiscal year 16. That was a $40,000 program. Our scholarship program now is $280,000. This is where we're moving money into our loan repayment program. Our physician loan repayment program has 2 components to it. $650,000 is in a state fund only program, and then we have a HRSA grant that is a 50-50 match. The state provides $100,000 and HRSA provides $100,000 as well on that. The dentist loan repayment program, $200,000 in 16. Primary care accelerated track program in Savannah. This is for the residency program there, $180,000. The total appropriation for 16 is $1.4 million, and that is 2.3% of our overall budget. Slide 18 just gives you an idea of our loan repayment programs. Our board met last week. We made 26 physician loan repayment awards from the regular state-funded dollars. We made 3 loan repayment awards utilizing the HRSA grant, which is half state, half federal funds. And then we used all of the $200,000 under the dentist loan repayment awards, making 8 awards at $25,000 each. We are continuing to accept application for both of the physician loan repayments programs. There's just a small amount of money remaining in those 2, and we have a lot of interest for that. So we are still accepting applications for that, so we can utilize those funds. Our last program is our undergraduate medical education program. and that is no recommended changes. And on slide 20, it just gives you a little information about that program. We have 3 medical schools participating under that. Emory with 113 Georgia residents. Those are medical students that reside in Georgia. Mercer, 210 are under contract, and they have 432 medical students that are Georgia residents. And PCOM, the Osteopathic School Georgia campus, we currently have 10 students under contract with that, 200, and they have 235 residents, Georgia residents. The rate per student is $6,363. Total appropriation $2.1 million, which is 4% of our budget. Slide 21 just summarizes all of the governor's recommendations. Again, our original budget is $6.2 million. The governor's recommendations adds another $952,000 into the budget, which would make the recommended budget for fiscal year 17 $63.1 million. And I will be glad to answer any questions if there are.
Okay, any questions here? Here, I've got one for you. Let me ask you, under that, the rural physicians for rural areas, that HRSA state loan repayment program where it's a 1-to-1 match, is that at the maximum, is $100,000 the maximum that we can draw down on that?
We can draw down as much state dollars as you put in. That we've only asked for 100. Through HRSA, but I know some states get well over $1 million, but then that would be
it's not
$1 million.
capped at
It's not
100.
capped at all.
And it's a 1-to-1 match?
It's a 1-to-1 match. For
Are
every
you-
state dollar, they put in a dollar.
Are you any more restrictive as to how you use that HRSA money as opposed to if it's just strictly state dollars?
It does have a lot more restrictions on it. It has to be a non-profit, not-for-profit facility, usually your federally qualified health centers. A private practice would not be classified as not-for-profit, but a hospital-based practice, a hospital that's not-for-profit that owns the practice would qualify in it. It has to be in a HPSA, a health professional shortage area, and our original grant application was that it also had to be in a county of 35,000 or less.
Okay. But, mess your button there. Which one is that? Is that 18? Okay, I got you. Go ahead, Representative Hawkins. Go ahead.
I'm sorry, I wasn't trying to interrupt. How quickly can you get that money? If you apply now, can you get it for this 2017, or is this something?
I don't think the application cycle is open at this time for the HRSA grant.
Okay.
I have asked our representative in Washington, if we get additional funds, can we ask for additional funding? And so far they have not answered. He's pushed it up a level above him to answer for us to see if we can get additional.
So in your opinion, we would not be able to move this in 2017 budget?
I don't think so at this time. I hope to have an answer before the end of the week on that.
Oh, okay, great, thank you.
Let me ask you one other question. Under that HRSA loan program,
Yes.
are there, under that next slide down there, number 18, are there only 3 that were made using those dollars?
Yes.
Is that because that's all that applied, or?
Yes, but there are 2 more applications that I know that are coming in. And so, as I said, the application cycle is still open, so we get calls almost daily wanting to know if they can apply.
What's the amount?
It's $25,000 as well total.
Just like the other?
Just like the other for physicians. So we end up paying it $12,500 with the state funds and $12,500 with the federal, each award.
Traditionally, have we used all of those dollars?
Yes, we have. And they have, it's a 2-year contract. They signed a 2-year contract for that. The HRSA requires a 2-year contract So when we contract with them, we're contracting for 2 years to stay in the rural area.
But we can leverage the state dollar with a federal dollar to go with it.
Yes. Mm-hmm.
Okay. Anyone else have questions? Thank you.
Thank you.
Okay. Next, we're going to hear from President Bill Underwood with Mercer School of Medicine, and I think he's got a special guest with him that lives down in my area. They're somewhere near down there.
Mr. Chairman and members of the committee, thank you for having us here today. I do have a special guest with me, Dr. Jean Sumner, who is the new and incoming Dean of the Mercer School of Medicine. She will officially take office as Dean on July 1st of this year. She is well known as one of the leading experts in the country on rural medicine. She knows it not just from studying it, but by living rural medicine. She has practiced medicine in Wrightsville, Georgia, since she graduated from the Mercer School of Medicine in our first graduating class, and we're very fortunate to have her and looking forward to her leadership in the School of Medicine. I prepared some materials for you to talk about the School of Medicine and what we're doing with the investment that you all are making in the School of Medicine. We've partnered with the state of Georgia for now 35 years in conducting medical education. The first slide you have shows the Mercer Health Sciences Center and where the School of Medicine fits within the Mercer Health Sciences Center. We have 433 MD students this fall in the School of Medicine. That is the portion of the Health Sciences Center that we conduct in partnership with the state, but it's only a portion of the health sciences enterprise of the university. We have one of the largest colleges of nursing, one of the oldest colleges of nursing in the state, the Georgia Baptist College of Nursing. The College of Pharmacy is the largest pharmaceutical science program in the state. It's located here in Atlanta. We have a growing physician assistant program also here in Atlanta, a growing physical therapy program, and a public health program as well as part of the Mercer Health Sciences Center. There are also 4 affiliated teaching hospitals that comprise a part of this Mercer Health Sciences Center. The next slide shows the newest facility associated with the School of Medicine. This is located on our Savannah campus. It's a $30 million education and research facility. It is funded entirely with private dollars, plus use of a federal funding device called new market tax credits. But new market tax credits combined with private donations funded the entirety of this first-class facility. And the most important thing about this facility is it allows us to expand the size of our medical school class there in Savannah. So we have 433 students this year. With this facility, we will be able to expand to 480 students in the School of Medicine, and we're really happy to have that on board. We have 2 fundamental metrics that we use to measure our progress in the School of Medicine, and the first is the percentage of our graduates who are staying here in Georgia. More than 65% of our graduates remain in state. That's the highest percentage in the state and among the highest percentages in the nation. You see there that a recent study conducted by the AMA says that we are second nationally in the percentage of our graduates practicing in low-income areas. In our home state of Georgia, we're third nationally for the percentage practicing in rural areas of our home state, and we're third nationally for the percentage practicing in primary care. So we're very pleased with those outcomes. I think we are behind the universities of North Dakota and South Dakota, where the entire states qualify as rural areas. The LCME, which is our accrediting body, found during our last visit that our long-term track record of placement of graduates in rural and underserved communities in Georgia is among the best in the country, further substantiating those AMA study findings. The other metric that we use to measure our success, you'll see on the next slide, percentage of Mercer School of Medicine graduates entering core specialty residencies. These are primary care residencies plus emergency medicine, and you see that that percentage has been going up. This past year was the highest we've had, with 79% of our graduates going into primary care plus emergency medicine, and we're very pleased with that outcome as well. You've had some discussion today about the importance of residency slots being available. Our data show that about 90% of our graduates who enter residencies here in Georgia remain here in Georgia long term. About 52% who do their residency out of state also remain here in Georgia, so we get a lot of them back. But ideally, we'd like them to do their residency here in Georgia because that's where our success rate is the best. The governor set a goal a couple of years back of eventually adding 400 residency slots here in the state of Georgia, and I think we're making headway on that goal. If you turn to the next slide, you'll see some data that has not yet been publicly announced but will be soon. First of all, the bottom half of that slide, the new rural residency track in Sandersville that we're doing with the support of our longtime partners at Navicent Health. You all supported that initiative last year. We've just learned in the last few weeks that that initiative has received accreditation approval. That will be the first rural residency track in the nation in internal medicine. So we're really excited about that. Over the next 3 years, we will build up to 6 residents in Sandersville, all in internal medicine, and I think that's going to be a great model for other rural residency tracks here in the state and around the country. The larger residency announcement, which we'll be making in the next few weeks, is that in partnership with HCA and the Coliseum Medical Centers in Macon, we will begin the process of adding 92 residency slots there at the Coliseum hospitals. And you see, yeah, it's appropriate, believe me. This has been something that we've been working on a couple of years with them. You'll see that eventually 30 of those slots will be in internal medicine, 18 will be in family medicine, 16 will be in psychiatry, which is a critical need area in the state. And emergency medicine, Mr. Chairman, will have 18 of those residency slots. So we'll have another emergency medicine residency program in the state there in Macon. So I think that'll be a big boost. And then we'll have 10 residency slots in general surgery. The big obstacle to creating new residency slots, as you know, is that for the first 5 years, if they're at a new facility, they don't qualify for Medicaid reimbursement. And if a facility already has residency programs, they're not allowed to add more and receive funding support for them. It's an odd regulation that if you show that you have committed yourself to residencies and you've done it, and you've got experience with it, you can't add them. But if you've never done it before and you don't have any experience, you can. But that's the regulatory scheme we deal with. And Coliseum has never had residency programs, so they have no caps. HCA will have to bear the cost of the residents for the first 5 years before they're eligible for Medicaid reimbursement, and they're willing to do that. So this is a tremendous boost for us. There will be some other costs associated with it, costs in connection with faculty recruitment, faculty development, additional learning resources, library resources, but we're really excited about that. And you see on that handout the timetable for phasing in those new residency slots over the next 6 years. Our state appropriations are on the next slide. You've heard Sherry Tucker talk about this. The appropriation of $24 million for our operating grant this year includes a couple of special items that you approved last year, the additional funding to support the 3-year family medicine program, and then the funding to support the rural residency track in Sandersville. We're proud of the work we've done on this. Our total funding for 2016 is roughly the same as our funding was in 2016 years ago, and we've more than doubled the size of the medical school during that period of time. So I think we're producing a lot of value for the state. One of the other things that's very important to us is the last slide, and you see on that last slide medical school annual tuition. During the period where state funding was going down, some of that cost was passed on to the students, as it had to be, but we've just put a stop to that because the biggest threat to producing doctors who will go into primary care in underserved areas is taking on too much debt while they're in medical school. So you'll see that now for the last 5 consecutive years we have not increased tuition in the medical school. Obviously that produces some strain when the operating grant's not going up, but it's mission critical for us to do that. So thank you for the partnership. We like to give you a report every year so you feel like you're getting a return on your investment. And Mr. Chairman, that's my report, and I'll be glad to take any questions. Let me add, though, that I would like Dr. Sumner to just say a brief word about the rural residency track in Sandersville, because she's spearheaded that.
Well, the first word I'd have to say is thank you for trusting us with your precious dollars. I believe very strongly that physicians, the best job you can have is a small-town doctor. But you need special skills and you need training there. And with our very strong partner, Navicent, we were able to approach graduate medical education accrediting bodies for a internal medicine track. These residents will have a very vigorous and intense experience at Navicent. They will be committed through the match to return to Sandersville for their last 18 months. And when they're in Sandersville, we expect them to do what community-responsive physicians do. We expect them to follow their patients to the hospital, make house calls on people that need house calls, understand public health, understand that everybody in that community that practices any discipline is your partner and your colleague, and help build those skills that they'll need to survive in rural areas. So we sincerely appreciate your support of that effort, and we hope it'll be something you'll be very proud of. I feel like it will be, and it's something that we can replicate across this state and other areas. So.
And we really are hopeful that this will be a model.
Good. Thank you, Dr. Sumner. We appreciate the good work you're doing, and certainly she's been a real pioneer in rural health in this state and is recognized as one of the people who really know how it works. I just want to make sure I understood you correct. On these 92 slots, that's going to be funded by HCA with no cost to us. Is that correct?
Well, there's going to be cost to Mercer, but I will say...
No, I mean to the state.
To the state. There's no cost to the state.
Yeah. 92. Just want to make sure I understood that. And the other thing is that the tuition has remained stable for the last 3 or 4 or 5 years.
5 years. Yes.
Okay. Any questions? Okay.
Dr. Sumner, you've gone from being president of the board of medicine now to the dean. Are you going to run for governor 4 years from now?
Representative Hawkins, that year I spent over here cured my political aspirations.
We went through a little bit together, didn't we?
I appreciate all of your help on the Medical Practice Act, I can tell you. I'm honored and humbled to be the dean of Mercer University School of Medicine, but my passion is rural health.
I know.
Mercer's mission is rural health, and we are committed to changing rural Georgia.
And I'm so pleased to hear that you're going to be the dean over there. You're getting a great lady, I tell you.
You're very kind.
Well, you must have done a good job because we have no other questions. Thank you very much for being here with us today and giving us this report. Okay, next we're going to hear from Morehouse School of Medicine. Dr. Valerie Montgomery Rice is going to be here and give us some good words.
I think Cassandra's bringing up our slides. And I have with me our Senior Associate Dean of Education Affairs, Dr. Marty Elks. I think we have some handouts as we're passing, and I'll start, if that's okay. Chairman Parrish and members of the House Appropriations Health Subcommittee, let me say, first of all, thank you for having us here today, and I appreciate this opportunity to share an update with you. I welcome this visit today for really 3 reasons. First, my appearance gives me the opportunity to personally express to you all, on behalf of our trustees, our faculty, our staff, and our students, thank you to the General Assembly and the Governor for all of the support that you have given us since our founding 40 years ago. This is our 40th anniversary. It also provides me with an opportunity to give you sort of a brief update on the return on investment. And lastly, it gives me the opportunity to discuss a critical funding issue for Morehouse School of Medicine. So first, my thanks. This is heartfelt. Over these last 40 years, we've been committed to primary health care. Cassandra, first slide, please. You can see that 40 years ago, there was a great need. In 1970, according to the Medical Directory of Georgia, there were 3,927 practicing physicians in Georgia, and only 95 of those were black physicians. And for every white physician, there were 795 white people. But for every black physician, there was 13,810, and many of us were around in 1970. And we remember that most of that care was segregated. 1/3 of Georgia citizens were black, but only 1 out of 20 Georgia students entering medical school were black. Next. And a partnership was formed, and it was formed between the Georgia legislators and Morehouse School of Medicine. And so Morehouse was founded to improve the health and well-being of its citizens, individuals that reside in the communities that we care about, increase the diversity of the healthcare workforce, and then do that by addressing primary health care through programs in education, research, and service. And we did place a special emphasis on people of color and looking at rural communities and urban communities, because we know that urban communities are also underserved. We've expanded that to include Georgia, the nation, and the world. Next, please. And so as you can see, in this depiction here, in 1970, 95 black physicians. And then Morehouse School of Medicine was founded. And over those next 15 years or so, we admitted our first class, we had residency programs begin, and in 1985, we graduated our first 4-year program of students. And then you started to see our impact. You started to see not just the increase of number of black physicians in the state grow, but you saw how many directly or indirectly touch Morehouse School of Medicine. So when you look in 2008 with the 2,400 or so black physicians, you can see that 1/3 of them have touched Morehouse School of Medicine. Either they were educated with us in medical school or they did the residency training program with us. Next slide, please. But we still have a challenge in the state of Georgia. Every one of those red counties that you see there, you know that it is a medically underserved area. And so when you talk about our mission, why we were founded, I want to talk a little with you about mission alignment. Next slide. So what you see here, and you'll see this in a couple of the slides, this is our 2013-14. You can see all those tan areas are underserved, and you can see that we are beginning to touch many of the counties that are underserved with students coming out from there applying to the medical school. So 67 out of 159 counties in 2013. Hit the next slide, please. And in 2014, that went up to 71. And you can also see with that also the applicant pool increase. And next slide, please. And what you look at here, and you can hit it again, Cassandra, is that when we even look at our 2016 data, and this year we got 6,500 applications, you all, you can see that we continue to expand the number of counties where students are applying for. And we're getting on some of those east corridors and down there in the lower west where normally we wouldn't necessarily get applicants. Next slide. And you can see that we're giving those students an opportunity to interview. Now, we're not finished with the 2016 cycle yet. But this year, remember, we're going to increase our class size to 92. And that is because we have continued to see an increased number of students applying from the state of Georgia, and we've responded. Next. So you can see here, our goal is by 2017 to increase our class size to 100. When I got here in 2011, we were 56 students per year. I came to you all then and I told you we were going to be aggressive, and we've done that. And we've increased our class size. Next slide. And you can see we made a commitment that over 80% of those kids were going to come, over 70% of those kids were going to come from the state of Georgia, and we held up to that commitment where over 80% of them come from the state of Georgia. Next slide, please. But it's not just enough to get the students in. How do we ensure the quality while maintaining a commitment to our underserved areas? So this is a slide that looks at how we recruit for mission. All medical students, when they come to school, they do an entry questionnaire, and it asks them a couple of questions. Do you plan to work in an underserved area? And you can see that 59% of our kids who we bring in say they plan to, compared to 24% in the nation. The other question is, do you plan on going into primary care or core specialty? And you can see for Morehouse School of Medicine, primary care 61% compared to 34%, emergency medicine and surgery 20 to 16. And overall, though, 81% of our kids plan on doing something that's primary care or those core critical specialties that we care about. Next slide, please. Now remember, we bring in an academically diverse group of students because we really are trying to recruit students from these underserved areas. And you can see, if you look at this, our students outperform the level of expectation. So when you look at our entrance criteria of MCAT, you can see that ours is typically somewhere around 27 to 24 if you look at that blue line, compared to about 30 for the nation. But when you look at that step 1 score, which is that first objective measure that is compared nationally, you can see we shift that curve, and our students do extremely well. It is not unusual for us to have 100%, 90%, 98% first-time pass rate on the board. So we're not compromising quality for the diversity or recruiting kids from underserved and rural communities. Next slide. And just to show you that that data has been consistent since we've been tracking it thoroughly since 1993, where you look at step 1 or step 2. Our kids do extremely well. They're always well above that minimum pass line there at the bottom. Next slide, please. Now the question is, what do they do though when they graduate? So we know what they said when they got there, but you know, a lot of things happen in 4 years. Do they continue to choose mission? And you can see, based on the graduation questionnaire, and this is after the match, 70% of our kids plan to work in an underserved community compared to national. And do you plan to serve an underserved population, which is a different question, right? Because you can be in an urban community and care for an underserved population, and you can see that 65% of our kids do compared to 28%. Now, how do we do this? Part of it is, you all, the commitment and partnerships that we have in the rural areas. All of our kids in their 3rd year, they do a rural health experience. We partner with AHEC and others, and it really does make a difference. And these are all the areas that we expose them to. So even if we don't have a kid who comes from Georgia, we expose them to those underserved communities and those rural populations because we know that's going to make a difference. Next slide. And when you look at across from 2005 to 2015, you can see the national average is about 50%, and we are well above 63 to 73% of our kids continuing to match in those primary care or those core specialty. Now here's the exciting part. Next slide. Remember, all those red areas are underserved. This blue dots here looks at our students who have graduated. And if you hit it again, Cassandra, now you begin to see the impact of our GME graduates. So we are going to these states, going to the state, and we're going to these counties that are underserved. Because remember, that's our mission in progress. That's our continued mission in progress. Next slide, please. We believe the future of Morehouse School of Medicine is really linked to the health of Georgians. But we have some challenges. Next slide. Next. You all know about the Georgia workforce projections, and Sherry gave a good overview of the aging population, the population growth that we are experiencing. And so we know that when you look by 2030, we are expected to have a significant shortage in the primary care workforce. So what we do at Morehouse School of Medicine in partnership with our other medical schools makes a difference. Next slide. And even though we've seen, if you look at the top two lines, the blue and the red, you see that we've had over the years an increase in the number of Georgia students who are applying to medical school. And that means kids who graduate from high school in Georgia. But we know that that's not enough. We know that in order to get kids from Georgia, or to get doctors from Georgia to practice in the state of Georgia, we really do need to have a link between Georgia high school, Georgia medical school, a Georgia residency for GME, and that's what's going to produce Georgia doctors. I had the opportunity to present to the Georgia Board for Physician Workforce. I just want to share with you a couple of slides that we presented. Next slide. This slide is some data that all of us have been working on. Again, this is that map that you become familiar with, that medically underserved map for Georgia. All those little dots there, you all, represent a kid who graduated from high school in Georgia, what county they graduated from, and whether or not 4 years after college they went on to medical school. And I want you to notice that they're congregated in a certain area, aren't they? But look what happens in our rural areas. We have fewer and fewer dots. So there's something that's happening in more of those urban areas where kids are getting exposed to a healthcare profession or a possible health career option. In high school, that is probably influencing their thinking when they go to college about whether or not they want to go to medical school, etc. And so the rural work that we're going to do in partnership with the other medical schools is going to be really important. So the Georgia medical schools, we've gotten together and we've been working on this. We've been thinking about this. But we can't do it alone. Next slide. GME is critical because we know that GME is the single most important factor where physicians choose to practice. And so when we look at this, we know that if you connect high school and undergraduate medical education and GME, about 80% of them will remain in Georgia. If you look at it, you got high school and just GME, it's about 74%. You got undergraduate medical education and GME is about 72%, as compared to if they only do GME along here, it's about 48%, compared to if they just do medical school here, it's 45.7%. If you look at our Morehouse School of Medicine data, though, we know that it makes a difference. If we have our kids who go to medical school here and they do GME here with us, it's an 88% chance they're going to stay here and practice in the state of Georgia. If they go to any Georgia undergraduate medical school and go to Morehouse School of Medicine residency, it's going to be 74%. If they are a non-Georgian and they come to Morehouse School of Medicine for GME, 72%. So we said we convert people to Georgians all the time. And then if they go from a non-LCME graduate school to MSM GME, again, we convert them, 57%. And you can see how we compare here in the nation. But this is the slide that's most exciting for me, having been somebody who grew up in Bibb County and went to Southwest High School. If you go to a Georgia high school and you go to Morehouse School of Medicine, you do a Morehouse School of Medicine residency, there's a 91% chance you're going to practice in the state of Georgia. So I said we ought to invest some more dollars in what we're doing in the high school to influence these kids to think about coming back here from one of those and other connecting points. And then we got to have more GME slots for them to do their residency training. Morehouse School of Medicine has employees now. We have the capacity, you all, to increase our residency training slots by 51. So when we think about where we ought to allocate dollars, yes, we can expand new residency programs, but as you just heard, it costs a lot of money, and people ask the question, who's going to foot the bill for that? But there are residency training programs like ours at Morehouse School of Medicine where we can increase our complement, and we can do it in partnership with the hospitals. But we have to have stable funding through our state operating grant so that we can secure the faculty and a lot of the indirect costs that are associated with that, because Morehouse School of Medicine we run our own 7 residency training programs. We are the institutional official for our programs. So next slide. So why are we here today? Since 1991, Morehouse School of Medicine has received federal Medicaid match on its state operating grant, leveraging the state support. A similar arrangement, as you may recall, was also instituted for Mercer School of Medicine, but was replaced with state funding. This funding has been critical for the support of our medical student training, graduate residency, core faculty, and related patient care activities. Next slide. But we are continuing to have a challenge, and we're having a challenge because the state-federal funding arrangement has recently been a recurring challenge and problem because CMS did a big review. Now, yes, after some very scary conversations and work through with CMS, we were able to get them to agree to continue it. However, we believe that it was a short-lived victory, that the charitable contributions that are made through the hospital are tenuous at best. And why is that? Next slide. Because the federal funding available from the upper payment limit program are shrinking. This is secondary to the federal pressure to reduce health care costs, DSH cuts, Medicare cuts, putting pressure on MSM and all the entities receiving UPL. The federal matching funds will likely erode significantly or even terminate in the future as providers experience additional Medicare reimbursement cuts related to the HACs, the readmission challenges, etc. What we hope, next slide please, is that we can get some funding certainty, continue our expansion of our entering class of medical students from 84 to 100 by 2017, aggressively expand our GME residency training programs, and really serve Georgia's most vulnerable populations. In order to do that, though, we have to have secure funding. It is hard to go out and recruit the faculty, to talk to hospitals about expanding residency training programs, when every year we're having this concern on whether or not there's going to be some challenge with our charitable contributions. Our students come from household incomes on average of $58,000 a year. The average student who goes to medical school in this country comes from a household income of $175,000 a year. Our students are greater than $200,000 of debt, but they still significantly choose primary care and to practice in underserved areas. We too have not raised our tuition in the last 2 years because we could not justify raising tuition and then asking students to incur additional debt, but then putting in their heart to practice in underserved areas and to choose primary care. So we ask that you continue to support us with our state operating grant, and if the opportunity comes forward for us to look at an increase in that, such that we can get off of the charitable contribution, we ask for you to take in consideration the return on investment that we have provided for this state. It is our privilege and honor to do this work. As a native of Georgia, I cannot tell you how much it warms my heart to be able to come back and share my resources of learning from all of those places up north back to my home state. It continues to be a pleasure for me. I would be pleased to answer any of your questions. Thank you.
Thank you, Dr. Rice. We're glad you came back too. Do we have any questions from the committee? I just realized that the Dean of the House, Representative Smyrie, is attending, and certainly, Representative Smyrie, we'd love to hear any comments that you would like to make. I know you are a long-time supporter of Morehouse and very interested in what's going on over there, so if there's anything you'd like to say, we'd love to hear from you too.
Mr. Chairman, I'm delighted to be here with the committee and with my president, and her statement speaks for itself.
Thank you.
I look forward to continue to work with you and the members of this committee in
Thank
the
you.
process.
Thank you. Anybody? Well, Dr. Rice, we do have a question. Representative Gardner has a question.
I don't really have a question other than to applaud the efforts that you've made. We're glad you came back to Georgia. We're glad you're training doctors, particularly doctors of color, to stay in Georgia. We know they're needed. And I wanted to point out that Morehouse Medical School is actually in my district.
I asked that, I was going to guess that, but I thought
So let's help them, whatever they need.
Okay, thank you.
Thank you very much.
I think the biggest concern, Dr. Rice, and you correct me if I misspeak on this, is so much just the uncertainty about the future funding as it depends on the federal dollars that we've been able to draw down to
Exactly.
through the upper payment limits and other things.
We, as we said, we think it's a short-lived victory. We know that the governor's office and others work very, very hard with us to provide data to CMS for clarity of why this was done and how it was done. And so we got that cleared up, but it comes from the upper payment limit, and you all know that that is shrinking. And so we know that the Georgia Hospital Association stands with us in trying to get us out of that bucket, and we want to be out of that bucket because if we have stable funding, we can expand these residency training slots. And just like we applaud Mercer for being able to partner with HCA to be able to get those 90-some slots, imagine what another 51 slots would do for us in 7 critical areas: psychiatry, family medicine, internal medicine, all of those places where we know we need citizens to be able to experience the quality of care that'll make a difference.
We have a question from Representative Quick for you.
Really just a comment, Mr. Chairman. I was wondering if my good friend Representative Gartner actually also gleaned from some of this presentation that reliance on federal funding for long-term planning is tenuous at best sometimes. So that's the message I got. Thank you, Mr. Chairman.
Yeah.
Okay. Well, any other questions? Dr. Rice, thank you again for being here today, and we thank all of you who were here with us in attendance. We will just remind you that tomorrow, on Wednesday, we'll be having a public hearing in this room at 2 o'clock, and it'll be an opportunity for anyone who wants to speak to us on any concerns or requests that they have. There'll be a sign-up sheet here at the room, so when you come in, we'll be able to sign up, and then we'll try to limit those remarks and take into consideration the time restraints that we have in everybody's time. But thank you all very much for coming. We'll be adjourned.